Dear Chair, dear audience, the topic of my project is the effects of different additional therapies in cerebral palsy. My name is Márk Pulay. I participating in this program as a junior investigator, and I have graduated in the András Pető Faculty at Semmelweis University, which is one of the youngest faculty in the university. Our vision is that Pető method contributes to better quality of life of patients with cerebral palsy, and our mission is to find and implement new cutting-edge technologies and additional therapies which fit to the holistic approach of the Pető method. Therefore, we set up some specific goals. Don't afraid, I'm not going through the 4 projects because one topic is pulled together, and I will go to the details in the forthcoming few minutes. The first project is a systematic review and meta-analysis. We investigate the effects of additional whole-body vibration therapy among patients with cerebral palsy. But what is cerebral palsy? Cerebral palsy is caused mostly parinasal noxa and characterized by abnormal tone, such as spasticity and posture and movement, and we can divide them subtypes like hemiparesis or tetraparesis. You can also see the incidence rates of CP. We used to say that patients with cerebral palsy require lifelong therapy, conventional therapy, physiotherapy, or in Hungary, the well-known conductive education based on the Pető method. And many additional therapies and treatments are also available. And one of these promising treatments is the whole-body vibration. And you can see on this figure, this vibration platform can be used in different settings. Our aim is to evaluate the effects of this additional therapy, especially or the primary outcome in changing in musculoskeletal system. Therefore, our PICO framework looks like this. So the intervention group get conventional therapy plus this additional therapy. The comparison is the conventional therapy group only. And the main clinical question is, of course, related to the main outcome. Has this additional therapy beneficial effects on musculoskeletal system? We conducted a systematic search in the most frequent databases, and you can also see our search key. And finally, we got not only, but 16 eligible full text. Before I go to the details or in the results, it's important to understand because it's helped to understand the heterogeneity of this patient or population, because there are different type of CP and also different level of severity of CP. Therefore, there is a gold standard classification system. It's called gross motor function classification. And there, based on this classification system, there is a measurement. It's called gross motor function measurement. To understand, later I will discuss about these measurement outcomes, and the scale is starting from 0 to 100, and the higher number is corresponding for the better function. The first 2 walking-related outcomes, one of them is the walking speed, which measured by a centimeter per secondum. We used random effect model, and the difference of the mean differences, which is representing in the changes between the intervention and the control group. Here we can see that the first parameter is also statistically, but clinically is also important changes. Also in the second outcome, which is a step length, LA mean less affected side, because most studies investigating both sides of the participants, because there are almost always a less or the more affected side. It was almost also significant result. Another interesting topic or result is the changing in spasticity, which is mostly measured by ASFOR scale or modified ASFOR scale. We could pull together 3 studies. we see the clear tendency, but it's important to note that this ASPOR scale, it can be affected in many circumstances. Other two results, which is related to the gross motor function measure, domain D, which is the standing, and domain E, which is the walking, running, and jumping domain. We see also here positive tendencies, and there is a recommendation that only 1.3 points changing in gross motor function score, it can be clinically important or clinically relevant changes, and up to or more than 3.7 point changes, it's moderate changes. To summarize, we can see that there are promising effects on musculoskeletal system or on those outcomes, especially in walking parameters, but increasing the number of RCTs in the field could lead probably to more statistically significant results. I submitted this manuscript in the Disability and Rehabilitation Journal. The second project, which was a pilot RCT, this is about another additional therapy called pulse electromagnetic field therapy. The main outcome was the changing in dynamic or dynamic balance. Pulse electromagnetic field therapy shows already some convincing experiences in disorders such as abdominal muscle tone, for example, in sclerosis multiplex. But however, there is no evidence of this therapeutic approach in this CP population. And our aim is to assess the beneficial effects of this additional therapy, especially on how it can improve dynamic postural balance. Here is the PICO framework for this project, conventional therapy. This pilot was maintained or in Hungary, in the Pető András Faculty. So the conventional therapy was conductive education in our case right now. The intervention group get this conventional therapy plus this additional therapy, and the comparison was the conventional therapy group plus placebo. Here you can see the inclusion and exclusion criteria of the participants. In this pilot project, we involved 12 participants. This information is missing because of one animation, but it's important to highlight that this is a small pilot study. It was, as I told, single-centered, placebo-controlled, and randomized. Here you can see on this picture that the pulse electromagnetic field generated device, which is a pillow, and the participants get this pillow by sitting on their lap, and they get this intervention for 8 weeks, 16 minutes, and 3 times a week. Placebo group or SEM group get the same condition, but the device was turned off. I just would like to highlight some of the results of this pilot study. The most important results that there was no side effects, even in the washout period or the follow-up period. The body position that we use for the intervention and the type of the design, and most importantly, as an additional therapy, is important how you can integrate this therapy to the daily practice, to the daily therapy of the conventional therapy. And the stabilometer, which was one of the measurement techniques, it's already showed some slightly significant changes in the control group, but in the intervention group, but it's a really small sample size. We already submit this pilot study as well in the Journal of Developmental Disabilities. The third and the fourth project is based on this. So the third one will be a pre-study protocol. What will we change? We will increase the number of the subject, of course, and the crossover study design is nowadays getting popular in this patient population. We will change also the duration of the intervention and also will involve other measurement techniques. So this is the progress of this pre-study protocol, and the fourth one will be a randomized clinical trial based on this protocol. I would like to thank you for your attention. I would like to finish this, my presentation with this quote. I'm a little bit out of the time. Thank you very much.
So congratulations for your nice presentation. My question is that at the beginning of your presentation, you show us the heterogeneity of cerebral palsy. So my question is, have you seen any differences in your meta-analysis in the efficacy of this whole body vibration regarding the severity of CP?
Thank you for your question. I just go back because we do we call it subgroup visualization, because it's not the real subgroup because of the number of the involved studies. We cannot do meta-analysis from one or two studies, but we separate them like those studies where the participant has very high baseline values or higher baseline values, and those who have lower baseline values. Unfortunately, which is one of the limitations of some of the studies, that they don't report the severity of the CP in the involved population or subjects. Therefore, we wasn't able to divide them into this classification system. But also the all results, it shows that mostly the walking-related outcomes was significant, and also the tendency was more positive. It means that those children who was able to, for example, walk already, they probably in the less severe CP type. So yes, we capture this, but we have to be careful with because of the number of the included studies. So, but yes, thank you.
Yes, for your planned projects, so you are treating these patients with the conventional supportive therapy. So yes. Hopefully they will evolve and they will be better with time. And these other methods are coming as add-on therapy. So one part of the patients will get the conventional plus this vibration or electromagnetic pulse, and the others not. And then there will be a moment when you can compare them, and maybe there will be some plus. Or
yes, it's always a big question for us, because as we experience that all children has different family background as well. So it's always it's very often happen that they get some additional therapy after the school, after the conventional therapy. So this is why it's sometimes hard to separate the effects that these positive effects or improvement is co-used by which therapy, of course. But yes, we try to integrate these additional therapies into our daily conventional therapy.
And then to see the groups with and without, and then standardize the standard therapy.
Yes. And
to see
this is why the crossover study design is good, because in that case, the intervention, the control group will change. And if we captured positive tendencies, then it's a more transparent, or it's better maybe. Yes.
And then you can also see how long lasting are the effects, whether it works when they get it and then it wins and disappears.
Yes.
Thank you.
Thank you for your presentation. My question would be, I've seen there are quite a few cases in these articles, and you mentioned that you had a sample size calculation as well. Or
Not really. Yes, for the second study,
yeah,
the sample size
But
calculation.
how much was it? Like,
Yes, I don't remember the exact number, but this crossover study design helped with the sample size calculation as well, because in that case we don't need that many samples, because the intervention, the control group will change in one point, and this is how we can deal with this, because it's really difficult to have a relative homogeneous patient population or matched pairs. We have to match them because of the severity of CP. It makes sense that I don't match the type 5 CP patient with a type 1.
As I see in your meta-analysis, you have a before-after data, and you would like to estimate the change. In this situation, in some cases only before, after, and some cases the change is given. How you can handle this situation, and in your case it's happened or not?
If I understand well, so in all studies that we included, they reported or we text them and asked the raw data. So it was important that we have the baseline and also the after intervention test. In every cases we have the pre and post and pre means of the participants.
You can report a change if you have only the before after data and not direct change.
So if we because we compare the difference, the mean difference between the groups. So if I don't.
The problem is with the standard deviation. So if you have only the before and the after data, you can't directly calculate from this data the change, the standard deviation of the change. But how it's typically handled? I think in this case it's happened somehow.
We have the post-pre mean differences in each groups, and then we can calculate the difference between the mean differences. So tricky question.
So I assume that there was an imputation of correlation coefficients or something.
Yes, the test. You mean what kind of test was it, or?
No, for calculate the standard deviation of the change, you have to input a correlation coefficient.
So the T. Okay. Tricky question.
I think you could discuss this after the whole session and then give some advice. It was a very important topic, and I think with neonatology we have now many children who have this problem, and it's important to find the methods and devices to bring up the quality of life. So thank you very much.